This probably should be better titled bed mobility, and then we'll get into transfers later. So again, we're thinking with our patients, they're in the hospital setting, low levels. We're going to start with really dependent. I'll show you some mechanics for the dependent patients. And then we'll start thinking about, okay, as the patient's better able to progress, how are we going to get that patient better so they can do it by themselves? So we already talked about biomechanics. We just talked about it. If you fell asleep, you can start looking at that stuff and reviewing it. But transfer is a movement from one surface or location to another, or from one position to another position. Again, I typically call that bed mobility. So when you hear me talk about bed mobility, it's anything that goes with staying in the bed. Could be scooting up to the head of the bed, scooting down to the foot of the bed, shimmying to the one side or another, rolling over, all of that stuff I consider bed mobility. Some of our textbooks call that, no, that's still a transfer. So that's just a little term thing. You'll hear me usually use bed mobility for that part. But important for us to understand is it requires both physical and cognitive abilities. Our patients with knee replacements, now they don't have a really acute, they had it done an hour ago, they can't use that leg to help them roll over in bed. That can be really tough. Our patients who had a stroke and have, or actually, let's use a traumatic brain injury as an example. Traumatic brain injury, now we have a lot of cognitive issues. Now it's the sequencing and be able to understand how to do this. So it's still cognitive as well as physical. For us, oftentimes, especially as we're newer, it's easier to think of the physical abilities. Oh, they don't have this arm, they can't reach it. This arm's broken, whatever it might be, but it's also the cognition that can be a huge part of this as well. Now, especially in the hospital setting, there's a whole bunch of different medications. Anybody ever take a medication that just made them loopy, really affected their cognition? Even something as simple as Benadryl, where you go, wow, I'm loopy and drowsy. And so yeah, medications can have a part to do with the cognitive ability as well. That's one of the reasons why it makes working in the more acute setting so interesting and fun, is because even though you saw the patient at 8:30 in the morning and they did great, at 2:30 in the morning after their 1 o'clock medications, they could be completely different. So what we'll have to then start wrapping our heads around is the different assist levels. Now there are some slightly different definitions out there. So if you are looking at physical therapy related stuff on TikTok or wherever else you guys like to look at physical therapy related stuff, there might be some slightly different definitions out there. I will be referring, when we have our exams, and what I'm referring to, I am referring to this definition. So make sure if you are getting information from other materials, it could be slightly different. So make sure you understand that. So independent is the patient can perform without any cues or assistance. They are fine. Modified independence, they might require some cues. Hey, watch out for that. Clear out the space first, go around the stool, some sort of little cue for that. Or requires AD. You guys know what an AD is? Assistive device. So assistive device can be anything. What assistive devices could you think of? It could be what? A gait belt. Okay. Yep. Cane. Walker. What did you have? Oh, like a trapeze bar. Okay, that's a nice thought. Good. That's an unusual one to think of. Nice. Any others? AFO? Is that what you're thinking of? Yeah. Yep, sure. Absolutely. So our sit devices can be a whole bunch of things. The easiest, most common ones to think of are walkers and canes and crutches and things like that, but it could be a heck of a lot more, like trapeze bars, AFOs. Keep going on and on. So modified independent, some sort of equipment to be able to complete the task. Assistant, I don't usually use assisted, but it's here, requires assistance from another person, verbal or tactile cues, directions, or instructions. So more than just the one cue, more than just the, hey, watch out, I think my if we were to say gut feeling for assisted and modified independent is I don't have to be in the room when you can do it. The assisted is kind of like I just gotta be around. I gotta watch around. I gotta make sure like that kind of just gotta be a handful of feet away. That's how my gut feeling is for the difference between modified independent and assisted. Yeah, but I really think I think that's a poor definition of it, to tell you the truth. I think the verbal cue would be something like, "Hey, don't forget before you get up, lock the brakes. All right, I'll see you later." Like it's one of those kind of reminders. Better than a cue might be a better verbiage for it. Now, standby assist requires verbal close proximity, but not touching. So that's that. I just got to stand right here. Whoa, don't get you guys that were techs. You guys ever have a patient where you just go, whoa, stop getting up. I'm not there. Let me come next to you. You guys have those? So those people need standby assist. Yeah, they can probably do it physically by themselves, but something's probably going to go wrong at some point. I'm just going to be here for when it does, right? My 2-year-old's at standby assist level. If you have kids, then yeah, you're fine. Go ahead. I'm gonna be right here. Contact guard. What do you think now the difference is? Now we're making physical impact with our patients. Now we're going to be using the gait belt. We'll teach you how to use the gait belt properly. That's what we're going to be doing. Now, minimal assist is the patient performs greater than or equal to 75% of the activities. So these get a little weird. It's easy to write an exam question. Patient can perform 68% of activity. What is their assist level? It's easy to write those exam questions. It's easy to get those questions right if you know the definitions. What gets a little tougher is when you're moving with the patient and your job is to say, like, well, how much did the patient do? Well, if the patient weighs 100 pounds and you think you lifted 20 of them, all right, patient did 80%, they're at a min lit. So this is the kind of thing where it just takes a lot of reps with patients that aren't fully able to do it with. So we'll do our best to practice some of this stuff. I will ask that when you are with your lab partners and you're working hard, I want some reps where you're min assist. I want some reps where you're when max assist, right? And you need to have your therapist say, I think that was about a mod assist. And you say, yeah, that was right. Or no, I was trying for this. Like, so let's just start calibrating that way. But it's really not until we get a patient that's in our hands that we get to really start figuring that out. All right, mod assist is between 50 and 74%, max assist 25 to 49%, and then dependent patient performs less than 25% of the activity or requires more than one person to accomplish the activity safely. So this is really important information. And when we talk about bed mobility and transfers, there's some ways we can measure, make some concrete measurements, and there's other things that we do in the physical therapy world that are a lot harder to measure. And transfers are one of them. Transfers, it's really hard to measure. We can describe what we're seeing. We can say patient needed 7 cues day 1, 1 cue today. Like that's not a hard number. It's not like, measuring with a tape measure something, but it's something, right? It's still a measurement. And this is just a good way that we get to measure patient progress, right? If the patient was max assist day 1 and 2 weeks later they're at a min assist, that's great progress. So it is really important to understand these things. Here's the other thing to understand about it. If you're going to help your patient get up out of a chair and you read in the chart that they're a max assist, you better start protecting yourself, right? You got to make sure your body mechanics are on point. You got to make sure that okay, I've got this patient. Make sure you have your exit plan of, oh no, this isn't going well, because guess what? Patients who are max assist, things don't go well pretty often. So it just gives you that little piece to say like, okay, I know what to expect here. Now, it doesn't mean if you read in the chart, the patient was min assist at 8:30. Well, I just said how medications can really affect people, and that maybe later in the day or tomorrow they're not at min assist. So we can't just say, oh, great, we can't be lazy at all. And then in the testing situation in the school environment here, if we're going to help somebody do a sit to stand transfer, your mechanics, whether the patient's dependent or contact guard assist, what I see out of you from across the room should be exactly the same. Your mechanics, your body mechanics, your cues should all be the exact same. The only difference is the amount of effort on your face. And that's how I can tell approximately how much, what assist level. We'll get into that as we keep going. I'll remind you about that later. So again, pre-position is considered part of the transfer. I call it bed mobility. So you hear me say that all the time. Sitting up in bed before the sit to stand, moving side to side before going to side lying. We're rolling and side lying. Now, transfers in bed mobility are important to prevent contractures of the skin and muscles. So anybody ever get in an arm cast for a while? Yeah. What happened after you get the cast off? Just shriveled mess, first of all, but then what? Oh, the skin. Oh, I know the nutrition of the skin is poor, right? Can you straighten out the arm all the way? No, so that's a contracture, right? So when we leave a limb in a position for long enough, the muscles are going to atrophy and maintain that position. There's some physiology behind it. You guys know what a sarcomere is, right? The functional length of a muscle. It requires energy of the body to have sarcomeres. So if we're stuck in a position for a while, the body says, I don't want to exert that energy to keep those sarcomeres. Let's get rid of them. And now the muscle length is impacted, and we got to do something about that. So we want to prevent contractures because it's way easier to prevent these contractures from happening than it is to restore mobility once we get them. Next is skin breakdown. Pressure ulcers are a huge problem, especially in the hospital and skilled nursing facility settings. Pressure ulcers can happen very quickly. In as little as 2 hours, we can start to get pressure ulcer. I have had plenty of patients that haven't had any wounds, and then all of a sudden they spend the weekend in the recliner and now they have a significant wound. I saw them on Friday, I see them on Monday, and holy cow, this is way different. So it can happen very quickly. So patients who are immobile should be repositioned every 2 hours to prevent that skin breakdown. Why is preventing skin breakdown so important? Number one thing is for infection. If the second the skin is broken, now we have a high risk for infection. So yeah. We'll talk more about this stuff. If it's not next week, it'll be the week after when we go into positioning for our patient and thinking about how do we position our patient safely. But it is something just to highlight the importance of why are we learning how to move someone from supine to side lie to prone. Well, it's because we're going to be doing that for our patients every 2 hours to prevent skin breakdown. Each position that we put our patient in has different areas of body parts that are more at risk, and we'll explore more of that when we go into positioning later. I do want to just highlight patients who use a wheelchair for locomotion should perform pressure relief activity every 15 minutes. That's that push up on the armrest, get the rear end all the way off the chair, and then we can say every 15 minutes there should be something, just because of that high risk of skin breakdown at the ischial tuberosities. So there's some ways we have to document. Thorough documentation transfers include the ability to perform bed mobilities with what assistance, what surface the patient is transferring on, and 2, Ability for the patient to demonstrate safety techniques. Do they lock the brakes? Do they know they have to put their socks on? All of that is part of it as well. We do have some individual diagnoses, safety things. Is that important? When we say precautions, what does a precaution mean again? Be real careful. Yep. This first one should be a contraindication, but yeah. So when what did I say about the licensure exam and how in our notes or textbooks, whenever we see when something's not to do, what did I say? It's going to show up, right? It's going to show up on an exam. What not to do is almost more important than what to do. Is that what you're going to say? Put a star on it. Yep, put a star on it. Absolutely. All right, so if somebody has a hip replacement, this is a typo. Should be THR or THA. Total hip replacement, THR. Total hip arthroplasty, THA. Those are the abbreviations for that. So with the posterior lateral approach of hip replacements, I don't see a ton of these types of surgeries anymore. More we're going with the anterior approach, but it's really important to understand this because they still do happen. Don't flex the hip past 90 degrees. Don't adduct the leg or rotate. Typically, internal rotation is the big one for that. The reason for that is because of where the incision is, where they had to cut through the posterior capsule of the hip. When we flex past 90 degrees, the head of the femur is forced into that weakened spot of the capsule. Same thing if we adduct or internally rotate, and that is the position of dislocation after hip replacement. So we tell our patients, don't do this, right? So that is something we really have to teach our patients. I think in the next 10 years, we're not going to be seeing that type of hip replacement anymore. The anterior approach hip replacements. I can't remember the last time I saw a posterior lateral approach where they just have different precautions. So, but guess what? It's going to, if we stop seeing those type of surgeries in the next 10 years, it's going to take about 15 years for it to stop showing up on the licensure exam. So I think I'll be teaching this for a while. For spinal cord injuries, the abbreviation for that is SCI. They could have some bracing or casting to navigate. We want to avoid distraction and rotation of the spine. What do I mean by distraction? Look over there. No, that's not the type of distraction. What do I mean by distraction? Yeah, taking the two ends and separating them, right? So if the patient was laying here, I can't just take their legs and say, hey, come here, right? So that's that distraction of the joints. The log rolling technique is typically best. We'll look at that technique in a little bit. And low back pain trauma, avoid rotation. We'll see the log rolling technique is probably the technique to perform for that as well. We also want to document if there's any other equipment or assistive device used and the ability to progress towards independence. So I'll say this all the time. The first thing we should be doing as therapists, one, reviewing the chart, make sure we understand everything we need to about the patient. But when we start thinking about our treatment, what is your plan? What are we going to do? If we're going to be transferring, where are we going to go to? If you're excited and say, I'm going to get the patient out of bed, we go sit to stand and they say, okay, I want to sit down. And you look around and go, oh no, the chair's across the room. I wasn't planning on walking today. Now what? All right, we should have set up the room for success. So I'll talk about that a lot on how we're going to be planning that. So what transfer are you going to perform based on your record review, based on precautions, maybe weight-bearing statuses, maybe physician's orders, patient's ability to assist, goal of the treatment. All of that stuff is part of the plan as to what am I going to do here. What equipment are we going to use? We're going to use gait belts, likely wheelchairs, at least initially. There might be a recliner in the hospital room that we can use. A hospital bed, and again, if we're thinking we're in the hospital setting, we're going to be using the hospital bed. The footwear with non-skid soles must be worn. Could be those anti-slip socks. Could be something else, some other acceptable footwear. But we don't want slippery socks, and we don't want our patient bare feet. Maybe using a Hoyer lift or a trapeze bar, like you were talking about, that might be used. We'll talk about that in a little bit. Other factors: space in the room, exit plan, where are we going to go wrong and what are we going to do about it? Where can we back out? Are there any dangling clothing, IV lines, tubes that are going to get caught up? It gets complicated quick. I think a lot of times other healthcare providers and even as students, we look at and say like, oh, we're just going to get a patient out of bed. And then you go into the patient and they've got 6 different tubes hanging out of them. They've got the hospital Johnny that's dangling and getting caught in the far side bed rail that you didn't know about, right? So it gets complicated real quick. So what is your plan? Are you taking into account all of these different factors? We're going to educate our patient about what we're going to do. We always want to educate them on what we're going to do. And we're really going to try to wait for understanding. Something I'm not doing right now, am I? Every now and again I do, all right? Is everybody with me, right? Sometimes I get that, but right now I'm going, right? So I think as the new practitioner, it's really easy to say like, okay, I want to do this. I'm going to tell you how to do it. Let's go. When we just need sometimes that patient to think about what are we going to do. And it's okay to ask the patient, can you tell me what we're going to do? What did I just say to you? Because that's where you start getting we're kind of checking cognition at that point. 2, we're checking understanding and seeing like, okay, the patient forgot to tell me that they were going to reach to the side of the bed. When we start doing this, I'm going to make sure that they're going to do that because I think that's where they're going to make that mistake. Demonstrate if we're able to confirm understanding. So when we perform these transfers, we're going to start when I'm showing this stuff as the patient is dependent. They cannot help for some reason. And then we're going to progress our skills to, okay, the patient can help. When we progress to that, the patient's effort should always be 100%. We should never have to do more work than we need to. That's one of my rules. Become a lazy therapist. And I don't mean lazy because you don't want to work hard. I mean, if I have to provide 32% assistance for my patient, I don't want to provide more than that. 1, I want to play with my kids at the end of the day, so I'm not going to work any harder than I have to. 2, who's getting better? If I provide way more, who's going to get better, me or the patient? I'm the one that's going to get stronger, not the patient, right? So same thing if we went lifting, right? And you said, okay, Zach, I know you're working hard, but I need more weight. Put on more weight for me. We'll take it off for you and when it's your time for your reps. So if I start banging out these reps, Zach says, no, I can do this, right? And he gets underneath the bar and he starts going, right? Does it help him if I go, nope, didn't do it? No, what do we do when we're spotting each other at the gym? We do just enough to keep the bar moving, right? And that's exactly what we're going to be doing with our patients. Just enough that we're going to accomplish the task. The look on the patient, you guys know the look of maximum effort. You know that look on somebody's face? That's the look, that patient should have that look all the time. Does that make sense to everybody? That's a crucial thing because it's so easy for us just to do it for the patient. And I get a lot of flack from caregivers when I allow my patients to struggle and I'm not just lifting them up because that's what they do. They just want to get their loved one to stand. And I'm the one saying, you can work hard if you want. I got a long day ahead of me. And no, I'm making the patient work, right? That maximum effort look. Doesn't matter what the task is, it should be that maximum effort. We're keeping our body mechanics is crucial. We're going to start doing it in just a little bit, how crucial it is to keep good body mechanics. All right, so we're going to start with a dependent patient. There are times when we're going to need to do this, especially when we move our patients to position them in different spots so they have less risk for skin breakdowns and contractures. So we will be doing some of these. I think I hope that you guys never have to do the 2-person lifts and 3-person lifts. Those are really just emergency situations. If our patient's completely dependent and we know that it's a lifelong condition or a progressive condition, we should not be using our bodies to lift another person. We should be using Hoyer lifts, different machines to do it for us. We should be protecting ourselves and the rest of our staff too. It doesn't matter that the Hoyer lift's down the hall. We're going to protect our bodies and we're going to use that stuff. And that's what we should be telling the rest of our staff that we work with as well. Other ways we would need to be able to move a dependent patient to assist other members of the healthcare team. We need this wound on the backside of the patient needs to be debrided and cleaned and treated and put meds on. Someone needs to hold the patient in position so that the other healthcare personnel can do that task. In the home care setting, I helped my CNAs bathe and dress my patients and change the sheets on the bed all the time, right? Hey, before I go, do you need help with this? Oh, that would be so great, right? So yeah, I do it all the time to assist other healthcare members. So it's not something that's common, but it is something every now and again we'll need these skills. All right. So do we have a Hoyer? All right. So at some point we'll glance at what a Hoyer looks like so everybody can just at least see what it looks like. If you're in a setting, not today, we'll look at it next week. If you're in a setting that uses them a lot, you'll be really familiar with them. And if you're not, you'll just know that it's a tool for you should you ever need it at some point. So what we're going to do is we're going to go through the transfer sheet draw. We're going to go rolling to from supine to prone, and then we're going to go supine to sit. So what we're going to do is we're going to use that room's open now, Tone. Okay, so we're going to go in that other room. We have a hospital bed in there that we get to use. I'll show you these techniques, and then we'll practice hard on these, okay? Feel free to get as much space around as you want. So this is exactly what I mean about setting up the room for success. Right now, I don't think this is in my way, but if it was, I'd have to move it. Now, one other thing, what we're going to do, I need this bed moved away from the wall. So I need to at least move the bed away from the wall so that whoever's helping me can be on that side. So now this might be in the way. Okay. So something else about the anatomy of these beds. So, you know, each bed is slightly different. So each manufacturer has slightly different things. We have this is not plugged in. Oh, there we go. All right, so there's the bed rails. We'll need them out of our way because we don't want to add obstacles. Again, if we're going to keep our body mechanics, if I needed to do something with my patient, this bed rail, how does that do for my body mechanics? Right? It immediately becomes a problem. I can't keep short arms with something else that's blocking me. But there is the up and down features of everything we might need. So that's great. Now, we have a lot of different heights in here. You should be lifting the height of the bed so it fits you, right? And I say that to you because you're the tallest guy here right now, but for all of us, we should be adjusting the height of the bed so it fits you. Once their feet need to come in contact with the ground, we can raise or lower the bed. But since you're the one that's going to be doing the lifting, we need to protect your bodies. Okay. All right. So we also have that room we'll be using as well. All right. I need a patient and one other therapist with me. Perfect. Smart. Your job as a patient. Can you lay down? Brilliant, right? All right. Who's going to be the therapist with me? Perfect. All right. So let's see. So brakes are locked, so we want to unlock the brake. We'll give you a little bit of space on that side. You're going to go on the far side. And then I need to put the brakes on again, okay? Give a little shift just to make sure it is. All right, perfect. So the next thing we're going to do is right now, again, starting with the dependent patient, right? They can't help us for some reason. We're going to be using the draw sheet to help us move the patient. We're going to practice going up. We're going to practice going down. We're going to be doing side to side as well. So what we need to do is first, my hand position, I need to be able to kind of cradle the head, but I can't go way too high because I need most of my power. My power needs to become to his hip and shoulder girdles. So if I'm way too low, I'm going to be not near the heavy parts of his body that I need to lift. But I still need to cradle his head a little bit, and I still need to make sure that his legs aren't just going to be dangling either. So that's part of this little feeling out process. Now, maybe the patient has good neck strength, but no other ability. You know, we just have to kind of apply this thinking to the patient in our hands. So next thing I'm going to do, I'm going to get a bunch of the material in my hand. All right. So I want to fill my hand with as much material as possible. Yeah.
You need to let her have a little more space. I'm afraid she's going to trip. It's things sticking out.
Is there?
Yeah.
All right. That better?
Yeah, much better.
All right. Thank you. Thanks for seeing that. All right. So I'm going to gather as much material as I possibly can in both hands. All right. So you're going to do the same thing. Now, right now he's a little bit shifted to me. That's okay. What you might need to do, and we have to figure out which direction we're going to go first. Go ahead and grip a bunch of material. And when you also want to kind of be close to him here, I don't want to lift him out here. Okay. So I want to be close. Now, there's a lot of space in between him and the side of the bed, less so on this side. If you think you have to, throw that knee up on the bed. Yeah, good. Do you see how it brings you a lot closer? Did everybody see that? Right. So again, this is one of those, I'll show you a couple of tricks, and whoever the patient is and wherever we're going will determine which tricks and tips we need. So there's some fundamentals that we have, and then there's some tricks and tips along the way too. All right. So the first thing we're going to do, we're going to move down. One person is the lead. We can't have more than one voice. We can't have more than one person counting or saying anything to the patient, right? So luckily our patient's dependent. They don't need to know we're good. All right, so gather material. Feel comfortable there? Okay. I think that'll work fine. Good. There you go. Good. All right, so we're going to move to the foot of the bed, okay? On my count, 1, 2, 3, lift up and slide down. There you go. Good. How did that feel to you? Good. A lot of effort or not too bad? Okay, so then let's move back up to the top of the bed. Good. All right, 1, 2, 3. Good. All right. So now next thing we're going to have to work on is side to side. So we're going to move him to you next. Okay. So now because we're moving to her, she might not be able to have that knee there. We just have to kind of figure that out. And because we're moving further away from me, I might take a little bit of real estate now, knowing that once I go there, I'll be in a good spot. Again, the size of the patient's definitely going to matter to this. Some of the beds are a lot wider. Some of the handrails stick out a lot further, which makes us further away. So again, we just have to figure this stuff out depending on the person that's in front of us in the environment. Okay. All right. So we're going to go to you on my count. Feel comfortable? 1, 2, 3, go to you. Good. All right. Then back to me. 1, 2, 3, back to me. Good. All right. That's all it is for now. Okay. Now there's a couple of skills to this is making sure, you know, having the sheet in our hands, making sure the one person is the lead. what Tony had said earlier is we want to make sure that our palms are up as we're holding this. Because if we have our palms down, if this starts to slip, it's gonna come right out of our hands. Versus if we're here, we've got a really nice grip right there. It's not gonna go anywhere, okay? All right, any questions on the draw sheet? All right, so we've got a couple of beds here. What do you have, like 4 in the other room?
Yeah, I have to see what we're doing.
Okay,
I do.
sure, yep,
When you're first learning how to move somebody up to the head of the bed, always put a pillow between the head base and them, because you're gonna be surprised how quickly they move up and you don't wanna crash their head into the top of the bed.
yeah, yep. All right, the last thing I'll say, and we'll say it at the end of the class, the nursing department is being kind enough to let us use all their equipment. We want to make sure we take care of it. So make sure if there's any equipment that you're not sure, hey, this button doesn't seem like it's working, let us know. And then at the end of class, we're going to put everything back and tuck everything in and make all the beds like it was presented to us, okay? All right, so we've got this bed, we've got some in the other room. We also have some bigger beds in the what's on the OTA side. We can use that if we need to, okay? All right, let's play. All right, so we already crossed the leg, we already tucked this arm in. Next up, hand goes shoulder and hip. My partner's gonna do the same thing, okay? We're gonna start roll to sideline. 1, 2, 3, go, go, go. Stop there. How do you feel? All right, so she moved her arm. If this is a dependent patient, this arm is going to flop down. Now it's in my way. Now we're coming on top of it. So the reason I put my hand there is because I stop it from flopping and getting in my way. Okay. So from here, if everything feels okay, we can just continue onward this. Now I'm going to change my hand positioning slightly forward, and I'm going to slow the descend of my patient. Come on, down slow, down slow, down slow. Good. From here, we can position my patient's limbs, get this out from underneath. We'll learn next week, pillows everywhere, and we say, okay, good. Okay?
Make sure that head isn't stuffed in the pillow on this.
Yeah, yep. So that's how we would go from supine to side lie and then to prone. Now, let's make it a little tougher. Thank you. You ready? All right, so the next thing, we got to have plenty of sheets on both sides. All right. So now we've got a bigger person. Now we've got a little bit more. Now I have to be careful, right? But do we have enough real estate for him just to go supine to? No, if we did that now, he would fall off the bed. So we're going to slide him that way first. Ready? 1, 2, 3. Good. As far over as possible. We'll cross the legs again unless hip replacement. How much real estate do we have over there? Do we have any more room?
You can go a tad more shoulders
Oh.
up.
All right, 1, 2, 3. That good? Okay. All right, tuck this arm in. Again, that's what I prefer. Tony, you prefer going up overhead if you can, right? Is that what you? Yeah. All right. So tuck this in. If I have it out a little bit, it turns into a speed bump. Like I can't get over it. So tuck it in as close as possible. Now, we're going to come to me. I'm going to put my hand on your hip and shoulders. We're going to lie on your side. He and I then will shimmy you back that way before we come all the way down. Okay. All right. So I'm going to put my hand on your hip and shoulder. You feeling okay there? All right. I'm going to try. I'm going to need a lot of help from you. Okay. 1, 2, 3. Good. I'm going to hold him still. You see how my hand blocked this from getting in my way. Now I'm going to hold him. You go ahead and get your sheet ready. He's going to do that same sheet technique where he's going to grab on the sheet, because if I kept rolling off, we're probably ending up on the floor, aren't we? Right. So, make a little bit of a wall here. So get your hands kind of up there and kind of there, because once I let go, I don't want him rolling back. Right. So yeah, you're right there. Give a little wall. Feel good. All right. I'm going to do the same thing here and here. Everything feel good to you?
Yeah.
Okay. On my count, we'll slide him to you. 1, 2, 3, go. Good. All right, I've got him. We're gonna slow him down. Okay, we're gonna lie all the way face down now, okay? 1, 2, 3. Good, and then we can untuck. Good, there we go, and then we'll figure out if he's comfortable or not. Okay, so it's that little in-between pause just because I ran out of real estate. So a lot different between the two different body types, right? Who had a question? I thought I had enough real estate. Once I was done, I would definitely move her to the center. But I didn't think I needed to. I easily can. I easily can. And I probably didn't move her that way enough before we even started anything. I probably needed to move her that way just a little further. All right. A little bit more complicated, right? All right, let's give it some reps. All right, so the next thing we're gonna talk about is how do we get our patients sitting at the edge of the bed? So, I mean, that's basically what we started talking about. Well, in the hospital, what do we want to do? Get out of bed, right? So that we have to sit at the edge of the bed before we can get out of it. Next week, we'll also start saying, okay, well, this is all dependent patient stuff. Next week, we'll start saying like, okay, they can start to participate. A lot of the fundamentals are the same. It's just now that we get the patient to start doing their job too. So we have two options to go to get to sit at the edge of the bed. The more common one we're probably going to use is this little scoop maneuver. So I need you at the edge of the bed. So if the patient was dependent, me and another person would get them here. So what I'm going to do is I'm going to put one hand underneath your shoulder girdle there. I'm going to put the other one behind your knees. What we're going to do is I'm going to give a little pull to your legs to get them off the edge of the bed. And as those legs come off, I'm going to pull you up to sit at the edge of the bed. Once we're sitting, I want you to have your hands nice and wide on the bed, okay? All right, what do you think we're going to do now? All right, good. All right, so remember when I said like we have to see if the patient understands, right? So okay, well, he's got the big picture, but right, so the what's the big thing I'm hoping he's going to repeat back to me? What's the one thing I really want his hands wide, right? Why do I want his hands wide once we sit up? So he's not going to fall down. Yeah, he's got wide base of support, right? So, all right. So I'm going to put my hand underneath your shoulder and your knees here, right? I want to get high school dance close, right? I don't want to get middle school dance close, right? So get underneath here. You okay here? Okay, we're going to sit up. Once we're up, I'm going to ask that you put your hands nice and wide, okay? Now, the big thing for me is it's really most of the work is pulling the legs off of the bed. Once the legs are off of the bed, gravity's going to push that down because he's all attached. He's going to kind of spring up on me. I don't have to do a ton of work with this side. Okay, you ready? 1, 2, 3. Good. Hands out wide. Good. And I like to stay in contact with him however I need to. Like if you wanted to just to stay here, that's fine. If you want to be here, fine. Because especially if he has a weird what was the blood pressure disorder that could orthostatic hypotension, right? So we go change positions, they get dizzy. Yeah. We don't want bad things to happen. So keeping in contact, at least for a few moments. Once we're here, I can start messing with the bed, making sure his feet are on the ground. No, this is one person. If I thought someone was going to fall back, I'd have my person standing right behind them still. Yeah. Yeah, and there's size differences too.
Yeah, what kind of situation if you were bigger, smaller, and you couldn't really get the hook around these legs? How would you compensate that?
Yep. We'd have to know the exact size difference and if the patient can assist or if they're completely dependent. Those are some of the factors that we'd have to start thinking about. Adding an extra person is always good. And, you know, to give a preview for next week and the patient can start assisting, go ahead and lay down. Maybe the patient doesn't need help. They just need help getting these legs off, right? So you're going to push down hard here. I'll pull these off. Maybe they only need help with that part. So I don't have an exact answer for you because the answer is always what? It depends. Yeah, right. So another person could be an option. Maybe they don't need help for everything. maybe just some things I don't know. Okay. So that's our first option, that little scoop method. Our second option, go supine, lay it flat on your back. Second option, I'll show on this side just so we have a better view on the camera. So the second option is just sitting to long sit. This is my least favorite. I think this is more taxing for me than the first one when the patient's truly dependent. But there are some times we'd like to use this one. So all we're gonna do is we're gonna sit straight up. You're wrestling, a WWE fan and all, you know, The Undertaker. Yeah, well, that's what we're gonna do. Okay. So again, whether I need one hand or two underneath of his back, I'm gonna put my hand here. All we're gonna do is we're gonna sit up tall. We're gonna wait. You're dependent, right?
All right.
All right, we're gonna sit up tall. If everything feels okay, then we're gonna swing your legs to the edge of the bed, okay? 1, 2, 3, up, 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 up. Good. How do you feel?
Good.
Now, if I was on the other side, I did it to this side just so we had a better view. I would then help the legs towards me this way. You see my body mechanics really fell apart, right? But if I was on that side, I'd be a little bit better. So we'd go all the way there, nice and wide. I'd be in contact all the time. Yeah, I did it to you just so we could see with the camera and that, but yes, that's exactly what I would do is lay flat. The method would be, come on up, 1, 2, 3, push, 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 push. Okay, now we're gonna swing to me. Good, and then relax. How do you feel? If everything feels good, then we operate the bed to get his feet into contact with the ground. The next thing I'd like you to do, so those are moderately easy for us. You're gonna be surprised how that scoop method, did it look hard? You're going to be surprised how easy it is once you get their legs off the bed. It's really smooth. The next thing I'd like us to do just to get in habits, let's put our gait belt on our patients, because if we're thinking, okay, maybe our treatment is just this. For most of our patients, the next move is out of the bed and we're going to need a gait belt on. So I just want to get some reps on just applying the gait belt. It goes teeth side first. Get it nice and snug. Put it in the other belt and then you can tuck it in there. What'd you say? Yeah. So it goes into the teeth side first, and then you can do it. You can get the tail in the other side of the clip. And then if you have excess, like we have for him, just tuck it in wherever you need, wherever it's out of your way, okay? And not gonna get hooked into the bed rails or anything else like that. All right, so I just want to get some reps with that. That's one part that'll take a handful of reps, okay? All right, so we got a bucket full of gait belts there. We've got 2 more things to get seated to the edge of the bed. Last 2 things we'll do for this class for today. Let's spend a good 30 minutes doing this stuff. Thank you.
Yep.
Now we are with a patient who can participate now. They've woken up from their their coma, their medications are now stable, whatever it might be, they can now start assisting. So let's go through all of our basic mobility to see how the patient can start assisting. So first step is moving side to side. What we're going to ask the patient to do is get into a bridge position. So bend your knees for me. Good. We're going to push down hard on these knees to lift up your pelvis. And then I want you to lift your pelvis to me. Now, my job is to provide as much assistance as they need, not any extra. Okay. So struggle with your bridge. Okay. So he's going to start push down hard on these knees, pick this hips up. Go, 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 then bring it to me, bring it to me, bring it to me, right? So that's that at the gym, we're lifting the bar and we're just keeping that momentum going, right? So I don't want to just do it for them. We can let everybody else do it for them. That's not my job. I got kids to throw around later, right? So then we can say, okay, next up, I want you to shimmy your shoulders to me, pick up your shoulders and shimmy to me. And it might take, let's reposition these feet, bring them to me, another bridge. It might take a bunch of little bridges. They're only moving a half an inch each time. Great, we'll do 20 bridges and we'll get to the side of the bed, right? So same thing, go in the opposite direction. To move up in the bed, what we need to do is do a bridge and then kick our legs out to slide up. Okay, so do a push down hard here, big bridge. All right, now straighten out your legs, push your body up, Good. All right, move to the foot of the bed. We're gonna do a bridge with a hamstring curl. Okay, yeah, a little tough, right? So push up hard. Now bring your butt to your heels, Good. Now you can reposition your feet. Same thing, big bridge, bring your butt to your heels, Good. So that's how we would start working with basic bed mobility, active assist. And again, I'm going to do what I can that the patient needs help with. I'm not going to do an ounce of energy extra. All right. Next up is the log roll technique. All right. So active assist to the edge of the bed. Get to the edge of the bed. Good. All right. So now there's a couple differences. The first difference is instead of crossing our leg, I'm going to have him bend this knee up. I'm going to have him bend that leg up. Now, what I'm going to cue him to do is he's going to push hard off of this leg because that's his power now. He's going to be launching his body that way. Now, when did we say the log roll was most important? What conditions? Any spinal problem. The great thing about the log roll is we eliminate rotation of the spine. We just have to teach that to our patient. So what we're going to want to do is we're going to want to keep this shoulder and this hip moving at the same time. You're going to roll like a log. All right. So we'll tuck this arm in because you're going to go over top of it. You're going to push hard on this leg to help get you moving. And what I want you to do, I want you to reach towards the edge of the bed. Now, we have hand rails that we could use if we wanted to today. And we could have our patient reaching to that. Not bad in the hospital. Do all my patients have handrails? Some do, most don't. So we'd want to progress to getting rid of this. But for today, if this is day one, great, we'll use it. So when I have you do push hard here, you're going to reach this hand towards the handrail. Once you can grab onto it, you can use that to pull. Okay. But the big key is to not rotate the spine. Okay. So we'll try it out. 1, 2, 3, push, reach, grab. There you go. Good. And stop right there. You feel okay? And if you feel like you can keep going, we can have you roll all the way forward, all the way down to your stomach if you want. Great. So good. Let's go back. You're good. When the patient's doing these movements, what am I doing? I'm cueing the entire time, right? And hopefully it's one word. If he was making a mistake in that one way, my one word cue would be to reach if he's leaving his arm dangling, right? So, but we should always be cueing and encouraging the entire way because you know what? He's working hard, right? Because he's working max effort because I am not, okay? All right, so that is our log roll. Go lie on your side facing me. We'll do the two getting to the edge of the bed. All right, so getting to the edge of the bed, my mechanics are all the same, except I'm providing a lot less work. What I teach my patient is push in with your elbow and your hand here. And you're going to really try to push these legs off of the bed as you're pushing hard here. Okay. 1, 2, 3, push. Arms out wide. Good. How do you feel? Right. So that's exactly what, again, it's basically the same thing as what we just did, except I get to work a lot less. So it's just great for me. All right. Last one, all the way flat. Supine to long sit. We're going to have you dig in with your elbows to bring your chest off, your back off of the bed. And as soon as you can straighten out your arms and come out to your hands. Okay. All right, I'm going to put my hands underneath your shoulders in case you need help. All right, push in with your elbows, push out to your hands. Nice job. How do you feel? All right, next step is, again, I would be on that side, but we're going to swing your legs off to the side and we'll sit at the edge of the bed. Okay, and again, if the patient needs 2 pounds of help to lift up those legs to clear it off the bed, I'll give them the 2 pounds. If he needs 12 pounds, I'll give him the 12 pounds, whatever the patient needs. Okay. All right, nice job. Any questions on that? All right, so next week, we're going to really practice this stuff a lot. Today, I think we've accomplished a ton.